This is the pronation supination test, or the rotation test. The movement's going to be initiated at the pelvis, and let's focus on the right limb. You'll see there's a bisection of the tibia and the calcaneus. So as you have the patient actively rotate, or with active assist from the therapist, there should be at least 45 degrees of rotation from the pelvis. If not, this would be abnormal. Now as we begin to rotate the pelvis to the right, that should take up the slack in a healthy hip and then begin to externally rotate the femur. Same for the knee. Assuming the knee is not excessively lax, that should begin to externally rotate the tibia, and the same for the ankle and the subtalar joint. It's not excessively lax. That should grasp onto the talus and abduct that into the transverse plane, and you'll see a forefoot compensation into relative adduction. Here it is up close. Notice the talus moves a bit more in the transverse plane than the calcaneus and the frontal. The angle from the leg to the rear foot can be estimated or measured. There's a moderate amount of pronation there. She really just shifts her center of mass from the lateral to the medial side, which may indicate a stiffness in the subtalar joint in general. She can't fully pronate, definitely doesn't excessively pronate, and she's also not supinating fully either. So this is likely a functional subtalar joint, but potentially a stiff one. Next, we're going to do a squat screen. Ask the patient to squat as low as they possibly can and observe. This patient obviously has excessive geni valgus and hip adduction. It's not quite so clear though how much of this is coming from the foot. So as we zoom in, we see that the line on the tibia and the line that goes down through the second ray is bowed, so that there is subtalar joint compensation. And as you cue the patient to avoid some of this compensation, you can see that their butt gets quite a bit lower, and the tibial second ray line is much more vertical, and there's much less internal rotation of the tibia, although there is some instability. Also, make a note that the butt can get a lot lower, and that gives you a clue that part of the improvement here may be that you're putting the hip more in its natural joint plane. And as we zoom in here at the toes, make a note of the second toe. On the right, it's gripping a lot harder than the toe on the left. Also make a note that the hallux on the right is abducted. It's beginning to cross over the second toe. The toe on the left is not. It's actually adducted. Also make a note of just the general weight bearing throughout all 5 toes and how all 5 toes are functioning. You can see navicular drop from this angle, but a medial view may be a bit easier. And from the rear view, you should see slight calcaneal eversion, approximately 3 toes, so slight forefoot abduction is okay. You see the tibias are vertical and symmetrical, which you can see here in this first image. That is not the case. The right tibia is more varus relative to the left tibia. You can also notice that the pelvis is tilted and the hands are asymmetrically positioned. With a little bit of correction, you can see that some of this has improved, but not fully. From the side view, we can make a note of dorsiflexion availability. We should see the tibia have about a 40 to 50 degree angle relative to the floor, and the knee go well past the toe, 3 to 4 inches. This one's a bit restricted. Knee flexion of 120, 130 degrees, femur just below parallel. The hip should be able to flex at least 120 degrees with a straight spine, and the arm should be in line with the tibia. Now, as we look at the elevated squat, we're going to notice that the arms are going to be much more in line with the tibia. The hands and even the forehead are essentially in line with the knee. There's much less hip flexion need, and her center of mass is much more well balanced. Now, with single leg stance, make sure the toes are roughly together before you start so the center of mass is under the base of support. You should see a very slight center of mass weight shift laterally. And observe that all the way through the head. You can see the EHL and anterior tib are active here. Make a note of toe gripping, hallux position. There's a little bit of rotation you can see at the toenail. And then take a look at subtalar consistency with balance. Is it consistently falling medially to the axis or laterally, or is it oscillating roughly around neutral, or slight pronation is actually normal? Now moving to the single leg heel raise or Stork, this is an advanced test which should display the rear foot's ability to invert on a everted forefoot. Now, pronation or supination is considered normal here. A fail is if they pronate and supinate to end range repetitively and aren't able to correct any mistakes that they make. You also want to see the heel be able to clearly expose the metatarsal heads, which is quite difficult here. And in an attempt to do so, she elevates her first ray off the ground and is unable to maintain the transverse arch, which should be formed between the first and fifth metatarsal heads. Now with the single leg squat, apply the same concepts to the setup with the single leg balance. This requires much less range of motion to perform, but does require a substantial amount of motor control from the foot all the way through the trunk. Additionally, this heavily tests strength of the plantar flexors, and particularly the soleus, and most notably the quadriceps. If you elevate the heel, that will remove some of the focus from the soleus and place that primarily on the knee extensors. Some refer to this as a sissy squat. And light fingertip support, if that stabilizes this and allows the motion to go substantially deeper, then you know that there is a heavy balance component to the test. And potentially less so, a strength component. And last, but of course not least, is the pistol squat. Nice job, Tiffany and Rob. This requires full expression of ankle dorsiflexion and knee flexion, hip flexion, and even a bit of lumbar flexion, and of course hamstring mobility. This can be used as a clearing test for pain in those high-level patients where symptoms are hard to reproduce, mobility deficits may be hard to put into context. It can also be used as a clearing test for return to sport.